Welcome, everyone. Thank you so much for joining us this evening. For those of you that don't know me, my name is Rachel Narwald. I'm a senior nurse practitioner with Northwell Health, Lenox Hill Hospital, and I work with Dr. Eugenia Gianos, who I know many of you know in preventive cardiology, and we're joined this evening by Dr. Anjori Dunbar. So if anyone is new to our lecture series, welcome. We're so happy to have you. We used to do these in person long before COVID happened, and now we do them every month virtually. So we like to pick topics that we think will be beneficial to the community, whether that's nutrition, heart health, healthy eating around the holidays, and this month happens to be Cholesterol Education Month. So we are so fortunate to have Dr. Dunbar with us. She works with our team in preventive cardiology, women's heart disease, and also advanced lipid disorders. So Dr. Dunbar, like Dr. Janos, is a lipid specialist. And of course, regular cardiologists know all about cholesterol, but there is actually an entirely separate exam, separate certification. So she is the perfect person to have with us this evening to teach us all about cholesterol. And we're going to be discussing what is the link between high cholesterol and heart disease, what type of lifestyle modifications can affect your management, and some new therapies on the horizon. So please feel free to put questions into the chat box. We will be more than happy to address the questions. You can put them in at any time. Dr. Dunbar is going to be giving us a nice jump into the talk with some slides, and then she and I will be having a discussion. So please feel free at any time to pop those questions in, and we will address them as time allows. So without further ado, Dr. Dunbar, thank you so much for joining us tonight.
Thank you so much, Rachel. I'm so excited to be here to talk to everyone about cholesterol, one of my favorite subjects. And thank you to everyone who is joining us. So yeah, I will be sharing my screen here. Give me 1 second.
Perfect.
Okay. All right, and hopefully you're able to see that okay?
Yes, perfect.
All right, wonderful. So yeah, so our topic today is talking about cholesterol, and we'd really like to get into all the details about cholesterol management and what you can do to reduce your risk when it comes to high cholesterol. So I'd like to start by just giving a few slides of background information on cholesterol so that everyone is on the same page as we get into our discussion. And then after this, Rachel and I will sort of go through some sort of frequently asked questions about cholesterol. And as you have questions that come up, if you put them in the chat, we'll definitely get to them. So as Rachel mentioned, September is Cholesterol Education Month by the CDC. And basically the point here is to raise awareness for patients about what high cholesterol is, what it can lead to, and really making sure that we have a good understanding of what we can do ourselves to decrease our risk of high cholesterol and what it leads to, and then the conversation around different treatments for high cholesterol. So the reason we care about cholesterol, because it's something that a lot of people don't really feel, right? Having high cholesterol is not something we feel like other sort of medical issues. The reason we care about it is because we know that having high cholesterol leads to development of what we call atherosclerosis, which is basically plaque buildup. I'm not sure if you can see my pointer, but this is just a cartoon of a blood vessel in a body, and this is specifically in the heart. And if plaque builds up in the blood vessel, that can lead to heart disease, which can lead to things like heart attacks. And if it happens in other blood vessels in our body, such as in the brain, that can lead to things like stroke. So we care about high cholesterol because it is a risk factor for development of heart disease and stroke, but it's not the only risk factor. So a discussion about cholesterol really does include a discussion of all the risk factors that go into development of heart disease. So as you can see here, these are some different risk factors that we go through with our patients when we're trying to figure out what their risk is for heart disease and how aggressively we need to manage different risk factors. And some of them are things we can't control that are out of our control, such as our family history. Certain races and ethnicities are at higher risk for development of this heart disease, our age and gender. And then there's medical conditions, including high cholesterol, but also high blood pressure, diabetes, and obesity. And then there's things we do every day, like what we're eating, how physically active we are, how much stress we have, and whether we're smoking. And then there's some other sort of unique conditions, such as sleep apnea, complications in pregnancy for women, and things like that. So a commonly asked question is, when should I check my cholesterol? How often should I be getting my cholesterol checked? So for children, it's actually recommended to get the cholesterol checked at least once when they're between 9 to 11 years old, and then again when they're 17 to 20. And this is really for healthy kids who don't have risk factors for high cholesterol starting at an earlier age. In those kids, we recommend starting earlier for cholesterol screening. And over the age of 20, for adults, we recommend at least once every 5 years, or again, more frequently if there are more risk factors. So the other thing I wanted to touch on is, understanding the test results. So when we get the cholesterol panel back, it has a lot of numbers, and what do all those numbers mean? So what is cholesterol? Cholesterol is sort of like a fat-like substance in the blood. It's transported through the body by these things called lipoproteins. And some of that is what we're reporting in test results when a cholesterol level is measured. So you may have seen on your test results, it always mentions a total cholesterol, and that's a sum of different parts of the cholesterol and how it's carried. And then, very simply, there's two big types of cholesterol that you'll see on the report. One is called an LDL, or a low density lipoprotein. Again, that's what's carrying the cholesterol. And then an HDL, or high density lipoprotein. And, to simplify things, we think of LDL as the bad cholesterol because it leads to increased high levels of LDL lead to heart disease. And then HDL is sort of the good cholesterol because it can help take some cholesterol out of plaque. And then triglycerides, which is another type of fat in the blood, is again not something good to have. And so higher levels of triglycerides can also lead to heart disease risk. But that's sort of the basic cholesterol panel that's reported. So going back to the reason we care about cholesterol is really to reduce the risk for heart disease. And this is from the American Heart Association. They're sort of essential aid for healthy living. And I think that's really important to sort of keep in mind as we talk about cholesterol, that again, we're not just focused on one thing. And, the goal is really to eat better, to be more active, to stop smoking. Sleep is very important for heart health, to maintain a healthy weight, to control the cholesterol, and that's going to be the bulk of our talk today, manage blood sugar and manage blood pressure. So how can we lower our cholesterol? So there's two sort of, ways that we think of cholesterol lowering. One is with lifestyle, and that's always our first step when we're talking about high cholesterol. And that includes what we're eating. So a heart healthy style of eating, being physically active and managing our weight, and then medications. And we'll talk about that in a little more detail too. So we talk about a heart healthy diet, and when I say diet, it really means our eating pattern. There's some diets that have been shown to reduce the risk for heart disease, and all of those are diets that we do recommend to our patients who have high cholesterol, and these are really considered heart healthy diets, and that's the Mediterranean diet, the vegetarian diet, the DASH diet, and really, the big focus of all of these types of eating patterns is to focus on things like fruits, vegetables, whole grains, legumes, nuts, and then really choosing healthier protein sources. So either vegetable proteins, lean meats, fish, and really staying away from red meats, processed meats, saturated fats, and prioritizing water over sweetened beverages like sodas, etc. And when we talk about being physically active, what does that mean? So the guidelines for Americans are to move about 150 minutes every week of doing moderate intensity, or 75 minutes a week of vigorous intensity exercise, and ideally spread out throughout the week. But really the goal here is just to move more. And research studies have shown that even sort of short bursts of activity are helpful. So even if you're able to add a few minutes of exercise, whether that's just walking a day, all of that is going to help a little bit your cholesterol, but also your overall heart health. And, again, sort of driving home the point that this is all about overall prevention for heart disease, that it's not just about the cholesterol. And this is what we do at our prevention program through Lenox Hill and Northwell, is go over all the risk factors and then what we can do to treat these risk factors. And this is our team here. You've already met Rachel. A lot of you already know Dr. Giannos, who heads our prevention program. And there's me. And with that, I'll turn it back to Rachel, and we'll get into some of the common questions we get asked about cholesterol.
Perfect. Thank you so much, Dr. Dunbar. That was a really great introduction. And I think it's so great that you talked about all the different types of cholesterol, because I feel like we get a lot of our patients saying that, okay, their cholesterol is borderline maybe, or their good cholesterol is high, so aren't they okay? What would you kind of say to that question?
Yeah, we definitely get asked that a lot. And, some of this has to do with sort of our thinking on cholesterol changes as we learn more about cholesterol. And, we used to think that having a very high good cholesterol sort of made up for having a high bad cholesterol. So we thought, okay, your bad cholesterol is high, I think your good cholesterol is high. So, that should be fine. But what we're realizing now is that bad cholesterol really carries a lot of weight. And we no longer think of the good cholesterol as sort of negating or protecting from that high bad cholesterol. And then the other thing to remember with these cholesterol numbers is, what we're reporting or measuring may not actually be a solid reflection of our cholesterol level. So especially with the good cholesterol, sometimes if we have too much of the good cholesterol, it actually may mean that the good cholesterol particles are not working as well. And that's why we have so many of them. So it's a little counterintuitive, but it can be too much of a good thing in a way. So, I think our risk reduction strategies are really focused on the bad cholesterol here. And so if you have a very good cholesterol, good. But I also care about what the bad cholesterol is, because that's really what's leading to development of that plaque.
Absolutely. And, I think in our clinic, we definitely try to do a really thorough risk assessment for our patients when they're first coming to us. It's so important for us to know about family history and any other conditions that may be contributing. Are there things that you're thinking about right off the bat that you think other patients should think about? What other risk factors are really contributing?
Yeah, so like you said, family history is really a big one. And really what we're trying to know is, do you have family history of, your relatives who have high cholesterol, or anyone who's had an event, so something having to do with the heart or stroke at a young age. And that's something really important, because if there is a genetic component to this, then that's something that we take into account. The other risk factors, like I mentioned, whether they have other conditions that lead to plaque development. So things like high blood pressure, diabetes, obesity. And then we do a full risk assessment of what one's lifestyle is like. So, we'll ask our patients, what are you eating? How much are you exercising, or even just how physically active you are? How much stress are you dealing with? And people have different sources of stress, and sort of learning how to help manage that stress will also help reduce heart disease risk. So, do you have any conditions that help, that make us wonder if you have sleep apnea, which is when you're not getting enough oxygen when you're sleeping. So we sort of think about it globally. And then, specifically for women, we have some, risk factors associated with them. So women we know who've had menopause at an early age are at higher risk for heart disease. Women who've had certain complications during their pregnancies are at higher risk. Women who have something we call polycystic ovarian syndrome, very specific, are associated with higher risk. And so these are all the things that we're thinking about, and this, as a more comprehensive risk assessment.
Absolutely. I think that's such an important point. I think a lot of women don't realize that their gynecological, their obstetric history can really be contributory. And, they may think, oh, well, I'm still young. Do I even need to see a cardiologist? I think especially when there's family history involved, we say you're never too young, to come and get checked out. It's always better to be coming at it from a preventative mindset, so that we can sort of identify any of that residual risk early on. And, a lot of our patients are hoping to avoid medication. So what would you tell people that are sort of hoping for a more natural approach, or they'd like to see what they can do on their end rather than jumping into medication?
For sure. So I think, again, it depends individually on the patient. We sort of think about people's risk in sort of two big categories: people who've had an event with their heart, or a stroke, and those who haven't. And in general, if you've had an event, you're at really high risk for something happening again. And for those patients, so first of all, for every patient, we recommend lifestyle. So that, it's not an either or. And I always tell the patients, you're not choosing one to not do the other. So lifestyle is always sort of the stepping stone for treatment here. And when people ask what you can do naturally, again, as we said, eating a healthier diet, exercising more, keeping track of your weight, all of those things will help reduce the cholesterol a little bit. But again, it depends on what their risk is. And some of the cholesterol medications, like the statin medications that are often the first sort of medication we use for high cholesterol, actually help heart disease. Patients who have plaque buildup already, it helps stabilize that plaque. So for those patients, I would say you're at higher risk. And, I think, again, with their discussion with their doctors, that I probably would not wait to start a cholesterol medication. On the other hand, if your cholesterol is lower and, we want sort of less of a reduction right off the bat, then I think waiting to see how the lifestyle changes lower your cholesterol, I think that's reasonable. I think, again, it also depends on individual patients. So everyone's body sort of, processes cholesterol differently. There's some, so cholesterol, part of it comes from what you're eating and you're absorbing, and part of it your body is making on its own. And I can't really predict and say who is doing more of what. So some people will make diet changes and, their cholesterol really comes down because they're absorbing a lot. Other patients, their own body is making a lot of cholesterol and they make big diet changes and it just, does not have an effect. Those diet changes are still very helpful for overall heart health. So I always say, keep doing what you're doing with that. But, it sort of depends. And sometimes we wait and see, we say, okay, let's see what we can do with lifestyle changes. And if you don't get enough of a lowering of the cholesterol, then, we say cholesterol medication is the next step. If the cholesterol to start out is severely high, or there is, risk factors that are sort of very significant, then we may want to start the medications up front.
Absolutely. I think that's such an important point. It's really a partnership that we try to have with our patients, because we can give you all the medications in the world, but if you're not doing those good lifestyle habits on your own, it's not always going to work out very well. And then on the flip side, it can be that you are doing wonderfully with your lifestyle, eating very well, exercising, but it gets to a point where we need to start thinking about medications. And I think that's one thing, that the cholesterol numbers are just a small part of it. I think you have really made that very clear, that there are benefits to these medications far beyond just the cholesterol numbers. And I know for me as a provider, I find it frustrating that a lot of my patients are really wanting to go the supplement route. And I'd love to hear your thoughts about that.
Yeah, that's a good question. I know sometimes when people think of, natural ways to lower cholesterol, this question of supplements always comes up. And, I think I really advise my patients to be sort of very cautious when it comes to supplements, because, some people don't realize that in general, the supplements are not going through the same FDA process, right? That medications are going through, that have to be FDA approved. So, anyone can sort of claim anything, right, if it's not going through the FDA approval process. And so even though something might say it's naturally derived, right, it doesn't necessarily mean that the pill you're taking really has exactly that compound that is being advertised. And it could have other things that could be harmful as well. And so, when it comes to things like vitamins, I always say if you have a deficiency in something, then you need it, but to supplement without sort of knowing if there's a deficiency, then I don't really recommend it. I will say, for people who have high cholesterol and are really trying to make changes with a diet, I think having a consult with a nutritionist can be really helpful, because, there are things like plant sterols that actually, can help lower the cholesterol, and people think of that as a more sort of natural source of doing that. Again, I wouldn't do that sort of on your own, but if you have someone like a nutritionist who can help guide you picking the right products, then I think that can be helpful.
Absolutely. And, a lot of times I'll tell patients, the reason we know about all the possible side effects and things is because the medications have been tested so rigorously for safety. And you're exactly right. With the supplements, it's all about marketing. They can say whatever they want to say. There's no regulatory body there. And I feel like one of the biggies that had a lot of really positive marketing with maybe not such positive data behind it is fish oil. So what would you say when your patients think that that's going to be a really great option for them?
Yeah, so that's a great point. So fish oil specifically can be helpful to lowering triglycerides. Okay, now fish oil is found also in fish. So the first thing I say is, the best way to get more of that is to eat more fish, especially things like salmon can be a really good source. Now we do have prescription medications that are sort of purified fish oil that we do think help lower triglycerides. But there's a lot of sort of controversy on the over-the-counter fish oils because one, the ratios are different, and the studies that show improvement in triglycerides with fish oil are done with a very specific sort of ratio and a very specific part of the fish oil. And then some of the fish oils are, carried with other substances in them that could actually be harmful. And so, again, I tell patients, if you have normal triglyceride levels and a doctor hasn't told you to start fish oil, just eat more fish.
Absolutely.
I don't think the fish oil is going to probably be that beneficial.
Completely agree. Yeah, there's likely not a benefit and could be some harm. And you're exactly right. I also tell patients your body doesn't utilize supplements as well as it does the food. So eat the garlic, eat the turmeric. The supplements are not likely. And some of these can actually increase bleeding, especially the fish oil as well. So for our patients that are already on blood thinners, it's definitely something to keep in mind that these, sort of more natural supplements do not come without risks for sure. And speaking about that, I think that there's unfortunately been a lot of bad press for the statins. And personally, I'm a huge proponent of them, a huge fan. But I'd love to just go through a couple myths with you, and we can educate our attendees a little bit. What would you say if somebody is worried that the statin might hurt their liver?
Good question. So I think before that, just so everyone's on the same page with what statins are, right? So statins are sort of a big group of cholesterol medications. And the reason we use them a lot, and if you go to a doctor with high cholesterol, they'll often tell you you need to start a statin. There's multiple types of statins out there. The two that really are higher effect, our higher potency statins are like atorvastatin and rosuvastatin. And the reason we use them is because not only do they lower your cholesterol, specifically the bad cholesterol, the LDL, we have lots of studies to show that lowering your cholesterol lowers the risk for heart disease. So we have, data from studies, research trials showing that the statin medicines lead to lower risk for heart disease. And that's why we use them. And, I sort of tell all my patients who I'm recommending a statin that, my goal is not to just bring a number down, because for a lot of them, you don't feel that number, right? So it's not affecting your day to day. And if a medicine brings a number down, it's sort of like, so what? Well, the reason is, one, we know that bringing down that number reduces the risk for heart disease, and specific data shows that using statin medications reduces the risk for heart disease. And specifically for people who are at higher risk. And that's why I wouldn't say that everyone who has a cholesterol number that comes back, on your report as abnormal needs a statin medication, right? So when we choose who to start it, it's people who are at higher risk. And, that's sort of between you and your doctor trying to figure out what your individual risk is and whether or not you need the medication. So that's just sort of a background on statins if you're not familiar with the group of medications. So yes, we get asked this question a lot. So statins do not damage your liver. And that's sort of what, I like to make sure people understand. So they don't cause liver damage. The reason we just even talk about statins and liver is that because the statin medications are metabolized, your body sort of processes them in the liver. So what does that mean? It means that if you have some sort of underlying liver problem, and it doesn't have to be a big issue with the liver, but if there's some fatty infiltration in the liver, that may mean that when a medication like a statin is processed through it, the liver enzymes may go up a little bit. Okay. And, just like any other thing that affects the liver, it's not like it's just the statin itself, but anything being processed by the liver can cause the liver enzymes to go up. If someone has normal liver enzymes and no liver issues, we really don't worry about the liver. It's extremely rare to have any liver damage, like I said, from the statin itself. But if you have liver issues, we may want to monitor it because we know that it's going through the liver. So it's something we think about, but we don't expect it to be something that hurts the liver.
Absolutely. And, exactly as you said, having very high cholesterol, having high triglycerides can cause fatty liver. So, sometimes people are already coming to us with that being an issue. And, we really want to make it clear to them, listen, the statin is one of the best things that we can do for you to help you get your cholesterol down, and help your liver to, listen, the liver regenerates. It's an amazing organ. So, I think that's one of the biggest things we want people to understand, that this actually might be really beneficial for you beyond just, as you said, just lowering your cholesterol. And how about a biggie that we get? Definitely, we have a lot of patients that either are diabetic or pre-diabetic or concerned about that because of family history, and they've maybe read that the statins can increase the blood sugar. What would you say to patients that are concerned about that?
Yeah, so similarly, again, statins are not going to cause diabetes, right? But I think it is something we think about for patients, because there can be a small increase in blood sugar really at higher doses and sort of longer use of statins. And it really, again, doesn't mean that the statin is causing diabetes, but in patients who are pre-diabetic, right, who already have higher blood sugars to begin with, there is, again, not in everyone, but there can be a slight increase in the blood sugar. However, I want to emphasize that the data on statins overall really comes out on benefit. So for someone who has diabetes, there is significant reduction for heart disease in those patients. So, if you're sort of borderline on the diabetes sort of, spectrum, and you start a statin and let's say the sugar goes up a little bit, that statin is still protecting you and it's still beneficial for you. So we really do think that, whenever we talk about medications or really any treatment, right, we always think of risk and benefit, right? What's the risk of something? What's the benefit? And a statin is a medication, so are a lot of other things. And with any sort of artificial thing or even natural things that we put in our body, right, there's always a risk and benefit. And for the statins, when it comes to the diabetes question, the benefit is much greater than the risk. So, that's sort of where we kind of do our risk benefit analysis. And even though there's a small signal for that increase in blood sugar, we don't think it changes that risk benefit ratio overall.
Absolutely. And, as you had said earlier, we're also counseling on improved diet and exercise habits, so that can often mitigate some of that or get them in a better place than they were when they even came to us. If somebody's already maybe possibly creeping into that pre-diabetic range, we're of course going to be addressing that. And as you said, referring to nutritionists, so we can really, really help people get into a better place even than they were at baseline. But let's say somebody's still not convinced, they're still really not wanting to start a medication. We've talked about lifestyle. How can we further risk stratify patients? What other tests would you consider for patients if we're at that place?
Yeah, so again, it depends. If someone already has significant heart disease, then, it's sort of a different conversation regarding the need for the medication. For someone who doesn't have heart disease and we're still sort of figuring out, one party was recommending statin, the other party is, and again, this is all a partnership between the patient and the doctor and the provider. And so, I really emphasize to patients that, be your own advocate. And if you really are not in agreement with what you're hearing, it is your body after all. So feel empowered to sort of have the conversation and bring up your concerns, because, it does, if the doctor is just prescribing a medication and giving you the prescription and you're not going to do anything with it, well, no one's helped in that situation, right? So if you have concerns about what's being recommended for your health, feel empowered to express your concerns. So having said all that, yes, there are other tests that we can do sometimes. So one thing that can be done is something called a calcium score. Again, we use it for patients who are not at that very high risk where, cholesterol medication is definitely recommended. But for patients in that sort of borderline or intermediate risk, we can do a calcium score, which is a CAT scan of the heart. And it's a very sort of quick CAT scan of the heart. There's not a significant amount of radiation with it. And it basically just gives us a number, a score of the amount of calcium in the blood vessels of the heart, with sort of the thinking being that, if there's plaque that's been there long enough to calcify, to show up as calcium on a scan, that means that, there is disease there, that you have had high cholesterol for long enough in your life, for that plaque to build up. So at this point, really, the goal is to prevent more plaque from building up. So, that may be a test that your doctor discusses with you. And, if you have no calcium, then maybe you wait a little bit before starting the cholesterol medication. But if you have a lot of calcium, then maybe you start a cholesterol medicine. So that test can sometimes help. And, this sort of brings up the point of, the exposure that your body has, right? So whenever we are seeing someone with high cholesterol, I always ask, how long have you had high cholesterol? Is it something that, just came up in your blood work last year, or have you had it for 5 years or 10 years? Has everyone always told you, hey, you have high cholesterol and we're going to watch it, for the last 20 years? And the reason is that we think this development of the plaque really has to do with the exposure over time. So your blood vessels, if they've been exposed to high cholesterol, let's say it's not terribly high, it's like mildly high, but you've been exposed to that mildly high cholesterol for a really long amount of time, that cumulative exposure, we think, is really what leads to all of this plaque buildup and then the cardiac events. So when we think about cholesterol, even if you've had sort of mildly high cholesterol, but it's been there for a long time, you're at higher risk, okay, than someone who, let's say, has had a really good cholesterol, and then due to, let's say, changing the lifestyle, that cholesterol really ramps up, right? And then they're able to sort of do lifestyle and bring it back down. That's a very different risk profile than someone really who's had a mildly high cholesterol for a long time, because their exposure is longer and higher overall.
Yeah. Yeah, absolutely. That's such a good point. And, also I think it ties into when we are treating our female patients, because I think women are often undertreated during childbearing years. And that's one of the big things that we try to counsel our patients is that, we don't have to just say, oh, well, never mind, we'll just wait until you're done having your family and then we'll consider dealing with it. No, that doesn't have to be the way it is anymore. We can really counsel people not only to get them optimized before pregnancies, but even throughout, if there's times that we can be a little more aggressive with treating and also working around family planning as it's possible. That's something that we really try to keep in mind. And I always want, our female listeners, whether it's for themselves or their family members, that this is not something that's mutually exclusive, that, you just not going to be able to deal with this until you're 40 or older. That's really outdated thinking. And, we really want women to know that it's never too early to get screened, to start addressing this, because as we know, your cholesterol goes up during pregnancy. There's lots of changes that happen during pregnancy. So it's really something that we try to advocate for our female patients to be aware of. And I think that it's maybe something that our female patients aren't thinking about, until they're a little bit older. And, speaking of that, would you advocate for genetic testing, for some of your patients? Is that something that you recommend to people, or you have specific parameters?
Yeah. So genetic testing, it can be really helpful. So when we talk about genetic testing, what we're generally referring to is that there's a condition called familial hypercholesterolemia. So basically, a genetic version of high cholesterol. And sometimes there are genetic markers that we can test for to see if you have that marker. And we know that people who have sort of marker proven, familial hypercholesterolemia, like we call it, they are at higher risk because, again, talking back to this exposure over time, if your body is just producing a lot more cholesterol and you just have a lot more cholesterol since you were a child, right? Your exposure has been that much more. So you're at higher risk earlier on in life. So for those patients, we may do the genetic testing, and that would impact their treatment and how, aggressive we are with lowering their cholesterol. And that we recommend, again, based on their risk, if they have that family history of, having people in the family who started having high cholesterol at a young age, if they have a family history of, their relatives having heart disease or strokes at a young age, those are the patients we think about. Or if they really have an extremely high cholesterol where we think, it's hard to get to those numbers, which is having a bad lifestyle. And sometimes that happens where, you almost are certain that there's got to be some genetic component to this. So for those patients, we may recommend genetic testing. And, at our center, we do it through genetic cardiologists who actually will have an assessment with the patient. And then speaking about sort of genetic testing, another sort of question that comes up is this type of cholesterol called lipoprotein A. And, we think of it as another sort of genetic cholesterol marker. And the reason is it basically, so it's called lipoprotein A. Some of you may have heard of it. And it's basically an LDL, so a bad cholesterol molecule with this A on it, basically. And what we know about this lipoprotein A is that having high levels of it does increase your risk for heart disease and stroke at a younger age. The question is, what do you do about it? So what's unfortunate about the lipoprotein A is that diet and exercise don't tend to change it that much. So it's sort of, I sort of explain it as it is what it is. And by the ages like 2 or 5, whatever number you have, it is what it is. And so sometimes we will check that because it would affect your overall risk assessment. So if we know that there is a marker of risk that we can't really bring down because we don't have good ways to bring it down at this point, then we really focus on the other risk factors and really try to optimize those as much as we can if we know there's something else that we can't modify. People ask, are there medications I can take to lower the lipoprotein A, which is really a great question and something that's being currently worked on in the field. There are medicines that will lower lipoprotein A, but we don't know at this point with the studies whether lowering the lipoprotein A will actually lower the risk for heart disease, sort of like we know about LDL, and whether these medicines that lower lipoprotein A, whether there's a direct then relationship to lowering the risk of heart disease. So, if we check it and it's high, then again, it helps sort of manage your other risk factors in the future. If we have medical treatments for it and your number is high, then, that can be important information. And then if it's high for you, your first degree relatives may also have it because there is a genetic component to it. So, they may want to be screened as well. So it can be another sort of helpful marker.
Absolutely. Yeah. Because we do have a lot of patients come and sort of say, what other advanced testing can I get? What other advanced lipid panels are there? So we're really kind of fortunate. It's just a quick blood test that we can do in the office. It doesn't matter if they're fasting for that one. Mm-hmm. So, it's a really easy thing. And I think a lot of providers, even cardiologists, are really not aware, are not testing for it. So that's another aspect where a lipid specialist is really important, and I think that that's something that maybe our audience members aren't as familiar with. When should they really be thinking about seeing a lipid specialist, versus just visiting their general cardiologist?
Yeah, and so we sort of talked about this before, but everyone should be getting cholesterol screening. And, again, some of you may get it more frequently based on your risk factors. And then, I think people who would benefit from a lipid specialist. So if your numbers are extremely high, if your doctor reads your report and says these numbers are, significantly high and higher than would be expected, because that might require some, a lot of medication to help bring it down or some specialized medications. If you're really struggling with side effects from the cholesterol medications. So, the statins are the most commonly used medications. And overall, they're pretty well tolerated. So, we have, as cardiologists, a lot of patients on these medications, and the majority of our patients do really well with them. But, I think people having muscle aches is, not I would say about 10% of people in clinical practice have it. In the trials, the rates are much lower, but, it is a concern to some patients. And if that's happening, then you might be a candidate for other medications other than the statin medications. And I think that's where a lipid specialist can really be helpful. And again, if you're someone who, everyone in your family has high cholesterol from a young age, where you're just sort of selected out as a higher risk person, then you may want to see a lipid specialist to really, take control of your numbers and really see what you can do to bring those numbers down.
Absolutely. Absolutely. And, you were mentioning the trials and things, we're very active in those as well. And it's also something that, you might have access to a whole world, not only of risk stratification and testing, but of treatment options, especially, where we're fortunate to be very heavily involved in research. And as you said, trying to figure out if lowering the LPA is really going to be a game changer in the future for our patients. And as you said, there is a world beyond statins. So, I'd love to get into some of the alternative therapies, if you will, some of the newer therapies. What other options are there? What do you think of right off the bat, kind of beyond statins?
Yep, so that's a great question. So, statins, it tends to be our sort of mainstay of lowering cholesterol because of everything we just talked about. But for some patients who their cholesterol needs to be even lower than they get with a statin, or for whatever reason they can't tolerate a statin medication, we do have a lot of other options. And this is really an exciting time in the field because we have sort of new medications coming out, and even in our practices, we're using new medications just in the last few months. So it is definitely sort of a growing part of our field. So we always sort of start sort of low, right? So start with what's been around and what's been shown to have outcome benefit, and that's you'll hear this term often from your doctors, outcomes, because again, we don't really care about numbers coming down if it doesn't translate into lowering the risk for heart disease, especially with something like cholesterol, where especially if you're young and healthy, this is not something we're talking about is going to change your life in the next couple of years, right? It may be sort of years down the line that we're trying to prevent as you get into your older years from having heart disease and stroke. So it's sort of a longer term game. So Zetia or ezetimibe is a medication that we often use as sort of the next step after statins. It's generally very well tolerated. It actually works on the cholesterol absorption in the gut. So that's where it works, and it's very well tolerated. It doesn't lower the cholesterol as much as the statins do, but it can actually work pretty well in combination with them to lower it further. And if you can't tolerate the statins, we do have patients who do well with the ezetimibe, and it's just a pill. And then the next sort of class of medicines that we'll often go to are injection medications for cholesterol. They're called PCSK9 inhibitor medications, and there's a couple of them out on the market, and they're very different than the statins. They are injections, and for most of them, you inject them every couple of weeks. Their side effect profile is, does not include the muscle aches and pains and some of these other things that the statins have. And some are for patients who really enjoy using them because they don't have to worry about taking a pill every day.
Yeah.
For some patients, it's a lot easier to manage with just the injection every couple of weeks. And these medications, the injection ones, can really lower the cholesterol, significantly, like 50 to 70% coming down on the cholesterol medication. So I think those three are sort of our big the medications we use: the statins, the ezetimibe, and then these injection medicines. And then the exciting part of the field are newer medicines that have come out. So there's something called bempedoic acid. There's some, which is a pill medication, specifically, proven for patients who've had issues with statins. There is inclisiran, which is an injection medicine that's actually given in an office setting, and after the first couple of doses every 6 months. So, talk about going from taking a pill every day to injecting every couple of weeks to now doing something twice a year, right? So now for the bempedoic acid and inclisiran, the outcome studies are still pending. So again, we know they lower the cholesterol, but in the next few years, we expect to see, similarly like with the other medicines, the benefit from heart disease. So we often won't start with them right away. They're sort of reserved for, if you're not able to tolerate one, we always go sort of step by step to maximize sort of the benefit from all of these medications.
Yeah, and I think it kind of goes back to what you were saying earlier about it being a partnership, with the patients, because of course we have an end goal, whether that's we know you have disease, or we're investigating the genetic conditions, or you're coming with very, very high cholesterol. So we're coming at it from a standpoint of here's what the guidelines tell us, but we want to work with the patient. And, we have a lot of people that maybe they can only tolerate a very low dosage of the statin. That's another exciting thing, that we have all of these options, because it may be that we can only have you on 5 milligrams of Crestor, but then we can add in the Zetia and we can really get you to goal. And that was one question that we do get a lot. If patients are specifically asking you about a number, do you sort of treat to a certain goal for the LDL?
That's a great question. I think the short answer is yes and no. So I think, again, it depends on the risk profile. In general, what we think of as sort of a normal LDL, I would say, is less than 100. And an ideal LDL is less than 70, I would say. If you have heart disease, our goal is definitely to get you less than 70. If you have heart disease, stroke, things like that. And, as we're getting more and more of these medicines that lower the cholesterol further and further and further, what we're seeing is that actually there's better risk reduction the lower and lower and lower you get with the cholesterol. So especially with injection medicines, where some of the studies had the cholesterols down to 30 for patients,
Right.
and it keeps showing that, lowering the cholesterol reduces the risk. So it's really an individual decision, and discussion with your patient and their overall risk on how low to go with their cholesterol. And we have actually, talking about sort of education month, we have for physicians and providers new guidelines that came out recently in the last few weeks, about using these non-statin therapies, because they do bring the cholesterol down so much, and really for a higher risk patients, targeting an LDL cholesterol less than 55. So 70 used to be sort of the number that everyone sort of aimed for. And now we know if you get it down to 55, there's even a more risk reduction. And that's sort of where the European guidelines have been. And some other countries have it even lower, of less than 30 for even the highest risk patients. So, I think in general, I think a good LDL for, people without any heart disease is probably less than 100.
Yeah, absolutely. And, that's just sort of an easy thing for us to check as providers. We get a lot of questions about, well, how are we going to monitor my disease? How are we going to keep an eye on this? So the cholesterol is just one part. It's a quick, easy thing. But what do you sort of guide your patients with? I know I'm not asking you any sort of black and white questions. These are all very much an it depends answer. But when people ask you, how are we going to keep an eye on this? What do you kind of tell people?
Yeah, so I think, like you said, check, if the concern is just the high cholesterol, then checking your cholesterol and, really, like you said, keeping an eye on it, right? So let's say with a shared sort of decision making, we decide not to start a cholesterol medication for now, and use lifestyle therapies to really bring it down as much as we can, then not forgetting about it, right? So not having like 2 years go by and not checking it, right? So to treat, really treat lifestyle therapies as a therapy, right? So if you're going to do lifestyle changes, you work with a nutritionist, increase your exercise, and check it in 3 months. And you sort of think about it as an issue rather than just something in the background that you get done every now and then. And so that, and then keeping all your other risk factors in check also, right? So that's why we, when we see someone for prevention for heart disease, it's not a I'll see you next year sort of thing often, right? It's I'll see you in a few months, and we'll talk about all of these different risk factors and where we are. And I think just, having sort of someone who's talking to you about all your risk factors, right? That can be really helpful, because we have to sort of be consciously thinking about risk factors to modify them. And if you don't think about them, then we won't do it. So, and then, if you do have heart disease, that question is a little trickier on how we sort of keep an eye on it. And, that really depends on someone's symptoms, whether or not they need sort of more testing.
Absolutely. And, I think it's also, you're often on a journey with your patients, where things are changing in their life. We have to keep that in mind, where this may be somebody that you start treating at 30, and then it's going to be a very different conversation, maybe at 65 than it was. And, I think it's important that people know that, we're looking much more kind of holistically, I think, at the patients, especially when it comes to prevention, because there's lots of other things, that can contribute. I think people recognize diabetes, but maybe don't think about other inflammatory conditions, autoimmune diseases, that these are things that contribute. And of course, we talked about women's health earlier. So I think that that's another important thing to keep in mind, that if somebody has lupus, maybe they should be seeing a cardiologist, I think maybe that inflammatory aspect is something that patients don't realize a lot.
Yeah, I think the inflammation and, like you said, the women's risk factors are often overlooked. And I do, as you were mentioning before, and a lot of these inflammatory conditions can affect women as well, right? So I think, we often don't prioritize heart disease in women, and women don't recognize heart disease as being important for women. And heart disease is the #1 killer of women, more than breast cancer, right? So first part of it is just sort of thinking about heart disease in women, and the specific sort of risk factors that you mentioned. So like the early menopause, and especially for women, talking about pregnancy is, I think, really important, because women are always concerned that they don't want to start medication, right? If they're planning on getting pregnant, which, we understand. And, if your risk is low, we wouldn't have you continue cholesterol medications in general during pregnancy. But what we do know is that cholesterol levels before pregnancy can impact outcomes during pregnancy. So if you're not immediately planning to conceive, I think, and you have really high cholesterol, getting that lower, whether it's through lifestyle or medications, can give you a better pregnancy outcome. And I think we don't think about it like that as patients, or as, a lot of times even physicians, we're not thinking about it like that. So I think it's important to realize how all of these things, including cholesterol, affect the body overall.
Absolutely. And, there's also things like that promote clotting, that women can then be having issues with when they're thinking about trying to get pregnant. And they might not even think, wow, should I be seeing a cardiologist, to sort of optimize my pregnancy outcomes? It might seem like
Right.
a huge leap for a 30-year-old woman,
Right.
so I think it's super important to get that message out for
Right.
sure.
And we do see, women who are planning fertility treatments because all of that affects the heart as well. And cholesterol is a part of that discussion also. So I think, hopefully we're trying to get the message out that, young women should, be being assessed by their doctors to see if they need sort of more specialized care.
Absolutely. And, then like you said, if there is a genetic condition that's identified, then thinking about future kids, children as young as 2 can be getting, screened. And I think people don't necessarily realize that either, right? They think, oh, well, my kids are under 12, so it doesn't matter, so
Right.
I think that's another thing to keep in mind, that this maybe isn't just impacting the patient specifically,
Right.
but families as
For sure.
well. And, I do want to be mindful of the time. I feel like I just chat with you all night. Please feel free to put in questions, everyone. You can just type them into the chat box and we are more than happy to address them. One question that we get a lot, Dr. Dunbar, is specifically healthy eating. So, I think a lot of times providers might say, oh, heart healthy diet, eat healthy, we'll see you in 3 months. What kind of specific advice? Is there a specific diet that you like to recommend for patients?
Great question. So I think of it sort of in two ways. So the first way is, that a heart healthy diet, whatever the diet may be, right? Focusing on, and again, it sort of sounds simple, but really focusing on the core sort of food groups, right? Like whole grains, fruits, vegetables, legumes, or that has got to be the core of the diet because, a lot of people have different preferences and it may be hard for them to follow a diet. But if you think of sort of are you getting your daily intake of, the fruits, vegetables, whole grains, legumes? That's sort of how I think about it. And then the other question is, if you really want to know, hey, what is proven out there, right, to help reduce my risk for heart disease, then a lot of people don't like hearing it, but I would say the vegetarian vegan diet is probably the one that has, the most benefits for the heart and even for weight loss. And so, a lot of times for our patients, we're also trying to manage weight, and the vegetarian vegan diet has some of the best data for it. So as much as we can, and again, when we say vegetarian, vegan, it's sort of very broad. It's really referring to sort of whole food based vegetarian diet. So, not sort of like a fries and,
Right, exactly.
vegetarian diet.
It's possible to be unhealthy vegetarian. So yeah.
Exactly. So that's really, if you really want to know what's proven now, what else is proven? So the DASH diet, which has been proven to reduce blood pressure. That focuses, so, again, is sort of focused on the fruits, vegetables, but also adds lean proteins, sort of like chicken and turkey to the diet. And then the Mediterranean diet is often sort of recommended for its heart health benefits. And, it really focuses on, in addition to the core groups, adding nuts, a lot of olive oil, avocados, or these healthy fats. And so, again, I think working with a nutritionist can be really helpful. Because they can guide you even, within your own cultural preferences. And just like we talked about with all this medications, sort of having that sort of conversation with the patient about, how the medication fits into the lifestyle. Same thing with, diet advice and exercise advice. It really depends on the patient.
Right. Absolutely. We do have some great questions coming in. One attendee asked, can you improve cholesterol when pregnant? That's a good question.
That's a great question. So sort of, Rachel, you touched on this, that cholesterol levels go higher in pregnancy. So especially the triglycerides, which is sort of that fatty substance, rises during pregnancy. So, the answer is yes, you can improve the cholesterol. Your lifestyle therapies of, what you can do with diet and exercise will help lower the cholesterol. It really, again, like I said, depends on your risk. There are some women who have heart disease who get pregnant, and we're managing their cholesterol, with sort of this higher risk. And, for them, we would have a discussion about the safety of continuing cholesterol medications. But for others, if we check the cholesterol and it's high, then we would really counsel on, maybe seeing a nutritionist. And, pregnancy can be a time when a lot of people are often encouraged to eat whatever they want. And realizing that, you can sort of get your weight gain that you need, optimal weight gain for the pregnancy, but focusing on the healthier foods. So if you do have the rise in that cholesterol, you're able to manage it. Because I really do think that managing that, even with lifestyle treatments and being active during pregnancy, will improve pregnancy outcomes and post-pregnancy outcomes.
Absolutely. Let's see. I think we have time for one more. This is a good question. I feel like you did touch on this, Dr. Dunbar, about sort of monitoring the disease process. But the question is, how quickly can cholesterol change? What would you say, sort of, if it's somebody working on lifestyle as far as retesting versus if you've started them on medication? Do you feel differently about the timing?
That's a great question. So again, it varies a little bit, but I would say with medications, you can start to see that effect on the cholesterol as early as 6 weeks. Anywhere between 6 to 12 weeks after making a medication change or starting a medication, I do recommend getting the cholesterol checked. Again, if someone is at higher risk, if they've just had a heart attack or something like that, and I really want to be aggressive with bringing down the cholesterol, I may check it in 6 weeks. On the other hand, if someone, is a lower risk patient, I may give it a couple of months. But usually, in a sort of a couple of months range is where I would recommend testing for lifestyle therapies. I usually give it at least sort of 3 months, to show a change. And then just the other thing is that the triglycerides part of the cholesterol, they're especially sensitive to changes in what you're eating and your physical activity. And, if you're not fasting, you might see those go up. So sometimes those we might check sooner. Because we know that they're so tied to how your lifestyle is that, even in a month, you might see that change if you've made a significant change.
Yes. Absolutely. And, we did have some kind of more specific dietary questions, just quickly. It is, that's a great question about how does sugar affect it? How do eggs affect it? I think, as Dr. Dunbar said, specifically, really the triglycerides are going to respond so much to that. And I think in general, thinking about things in moderation, there's no food group that we vilify, right? But it is, well, yeah.
Trans fats, no trans fats. Okay.
There you go. No trans fat. Yeah, Chinese food. We should probably, one of the attendants is always like, that's the only thing I tell patients not to have is Chinese food. So I think, how much do you think, Dr. Dunbar, that actual dietary, intake is going to be affecting the cholesterol?
Yeah. Again, I think it depends on the patient. Some people are very sensitive to the cholesterol they're taking in. I think sort of broad categories are, cholesterol is not just about the cholesterol that you're eating. So saturated fat is sort of a big thing that I would say to think about. And saturated fat is found in things like red meats, right? So that's why we say none of the heart healthy diets I mentioned talk about red meat. And it's really about minimizing red meat because it has a lot of saturated fat, and that can affect the cholesterol. I don't know if I touched on this, but increasing your fiber intake, especially soluble fiber intake, can help lower the cholesterol. That's sort of one of the first things we sort of assess. How much fiber intake are you getting? Eggs is a great question because the sort of feelings on eggs in the medical community seems to sort of fluctuate quite a bit. Eggs do have cholesterol in them. Okay, the question is, does sort of, limiting your intake of eggs affect your cholesterol? And again, I think it depends. I would say that if you have high cholesterol, right, that we're actively managing towards or managing with lifestyle or diet or medications, then it makes sense to limit the number of eggs. Okay. I would say I probably wouldn't eat eggs every day. And, if you don't have any cholesterol issues, I would still say, I would limit it to a few times a week sort of thing. And this is, sort of more of like a common sense type advice, because, and like I said, our feelings of it have changed over time, but it does have cholesterol in it. So it sort of makes sense not to overdo it, and, to limit it if you're making changes for high cholesterol.
Absolutely. Well, thank you so, so much, Dr. Dunbar. This has been fantastic. It is 8 o'clock. I want to be respectful of people's time. We're so, so grateful that everybody joined us this evening. And if anybody missed it or just wants to relive it later and rewatch it, it was recorded, and we do post these on our YouTube channel. It's Doc Heart Health. So DOC, like doctor, Doc Heart Health. And there's also some other talks that we've done, other fun videos. So you can go and check that out at any time. And we will be having another talk next month. And so we will always make sure to advertise well and make sure that you all know about the upcoming talks. Some may be of more interest to you than others, but you're welcome anytime. And thank you so much, Dr. Dunbar. We really, really appreciate having your expertise tonight.
Thank you so much, Rachel. It was a pleasure being here. And thank you to everyone who joined.
All right, everyone. Well, please have a wonderful rest of your evening and week, and hopefully we'll see you next month. Thanks so much.
Bye-bye.